have a avascular necrosis develop. We classify these traditionally according to Gardner's classification. He talks about 1, 2, 3 and 4. Let's make life really easy for ourselves. We don't need to bother about 1, 2, 3 and 4. 1 and 2, minimally displaced, really low risk of avascular necrosis. 3 and 4 are much more displaced, and we have a high risk of avascular necrosis. And that's all you need to do. The difference between 1 and 2 and 3 and 4, and you can spend 20 minutes arguing about it, is completely irrelevant. It has no prognostic value at all. Nigel's already talked about young patients, and I'm not going to talk about them anymore, other than to say that when we're treating femoral neck fractures, we have some things we want to try and achieve. We want to get the patient going. We don't want to have to do another operation. Seems reasonable. We don't want any complications. Another operation is a result of complications usually. We want the fracture to join up again, and we'd like to preserve the femoral head. That all makes perfect sense. And in a young patient, preserving the femoral head so that they don't develop avascular necrosis is more important than anything else. That's where our goals are. And if we put that patient on crutches for a month or two in order to help that, then that's fine. But in the elderly, we have a completely different set of aims. And our key is to get that patient up, get them moving, because if you put an old patient in bed, don't get them up quickly, then they won't move again well. We already know from Nigel their mobility is going to fall slightly after this. And quite frankly, if we throw their femoral head in a bucket in order to do that, that's fine by me and fine by them. So our priorities between young and old are totally different. Nigel's already talked to you about the fact that we've got different types of patients of the same age. Doing a fit and active, like this woman on her bicycle who's about to do a 100-mile cycle run at 70. And she's completely different from this 70-year-old who's getting around on a Zimmer frame and doesn't go out of the house. They're two patients with the same age and completely different needs, whose needs are getting different from this man who never gets to his feet. So we're dealing with different populations, although they're all lumped together as elderly. Undisplaced fractures, Nigel's already talked about a little bit. There's one there. You can treat this conservatively. Not very many people do, but if you do, the only publication I could find suggests that if you get them up and walk them, about 20% will turn from being undisplaced into displaced and then need surgery. So on the whole, we tend to fix them, which is the other alternative. And most of us use cannulated screws. There's some good evidence from Lindquist that clinically this is the best way to put the screws in. Run the screws up close to the cortical bone along the sides, because that way they get a better grip. In a triangular or inverse triangular configuration. You can use the dynamic hip screw, and you can use although Nigel's story was not as strong, there was one publication I found, because I hadn't read his one, that suggested actually this wasn't as strong as 3 cannulated screws. I don't think it matters very much, quite frankly. As long as you get it fixed solidly, that's what's important. Other devices simply don't work as well. I only use cannulated screws or use the GHS. These things were called Hansen pins, and they were diabolically awful. We used them some while ago. They're still around. I saw them advertised the other day. And there are other things people have come up with. If you're going to be offered an implant that you've not seen before and you've not heard about, you want good evidence that it works before you start using it. And there is no evidence about most of these other implants. Now, in the displaced fracture, we can reduce them and fix them. We can replace the femoral head with a unipolar or bipolar herniarthroplasty. We can replace the whole limb. to total hip replacement. So what should we be doing for our patients? What's the best thing to do? Nigel's already told you that they went through a phase in Scandinavia of reducing and fixing them, and they found a very high complication rate. And again, the Scandinavians randomised patients to total hip replacement or reduction and fixation, and they found unequivocally that the results were much better and they had a much lower complication rate where they did a total hip replacement. 42% were being reoperated on in this trial, and the function was much less good if you didn't have a hip replacement. Doing there are other trials where they've randomised fixation against hemiarthroplasty, and they found pretty much the same thing. Do not reduce and fix these fractures in the reasonably active looking patients. That's the sort of thing that happens. They did try in Scandinavia again. I've always been puzzled about how they got ethical committee approval for this in demented patients. And they did fixation against hemiarthroplasty. 60 patients. They found, in fact, that this group, the complication rate was about the same. The reoperation rate, there is no statistical difference between those two. But you can see clearly that the fixation group had a much higher reoperation rate. And the mortality rate was exactly the same in 2 years, very high. And they argue that there may be a place for fixation in completely demented patients. It will certainly stop them walking around, which may be a good thing if you're having to try and look after them, but I'm not sure that I buy that. Now, the mainstay of treatment in the UK and over the world for most of these patients has been a hemiarthroplasty. Here is an Austin Moore hemiarthroplasty. It's inexpensive, they're quick to do, you don't need very much training in orthopedics to do them, and they're technically easy, relatively. They come in unipolar versions, where we've got a head that's fixed to the stem firmly. This is two examples here. And they come in a bipolar version, which I expect you're familiar with, where we have an articulation between the head and the acetabulum, and another one between a small head and the big head. And the argument goes that because the small head can move within the big head, as well as the big head against the acetabulum, that you'll get less erosion of the acetabulum, which is the problem. Now, unipolar hemiarthroplasty done in the elderly, and this is work from Martin Parker, doesn't have a terribly good outcome, partly because of the patients we're dealing with. 500 consecutive patients from Martin Parker's series, 81% are dead in 8 years. So a very high mortality rate. But you'd expect that because it's a very elderly group. But of the survivors, 25% have been revised by 8 years. You imagine, put a hip replacement in, you've revised 25% of those by 8 years. You'd have to give up doing hip replacement. Okay. So the results for the survivors of hemiarthroplasty, unipolar, are awful. And they don't have a wonderful function. Any trial of hemiarthroplasty against total hip replacement suggests that. Problems? This is the one you can't get around. This is inherent to the implant. However good your surgery is, you're going to have a number of them that erode through the acetabulum. And up to 60% have been reported in various series. Infection, around about 4%, dislocation rate, related to how you put it in, and a significant number of patients get pain, loosening, and leg length inequality. There are two big questions in unipolar hemiarthroplasty. The first one is, how do we fix it in place? The second one is, which one should we use? Now, Nigel's already told you about the Thompson and the Austin Moore, which have been the mainstay for years, and I expect you do use them here in Egypt, those? Yeah, they're very familiar. Right. This is something called an accident trauma stem, which we started using in the UK now. How should we fix it? 17 trials, 2,000 odd patients, and there is no question that cement is better it's less painful, the mobility is better, and the complication rates of using cement are the same as the complication rates of not using cement. Those of you who haven't come to change them know there is one downside to using cement, and that's it's much more difficult to take them out again afterwards if you have to change them for any reason. So use cement is absolutely clearly the message. Which one should we use? Well, I'm not doing trauma, I'm doing revision hip replacement. And I can tell you that I hate getting a thin patient with poor quality bone in the cemented heavy arthroplasty because they're difficult to take out. But we need to use cement. So if we're going to use cement, we need to put an implant in that's easy to revise. They need to be inexpensive because we've got huge numbers of these and you don't want to be spending £1,000 or whatever the equivalent is in Egypt on the implant, and they must be easy to change for total hip replacement. And I want one that has got a good stem design, because as a hip replacement surgeon I know there are hips that work well and hips that don't. And one of the best cemented stem designs that are available are these four. This is what the evidence is, and I'll tell you more about that a bit later on today. But the Exeter and the CPT cemented stems, the Advanced SP and Spectrum. And it so happens that people who make the Exeter have made a stem that is identical to the Exeter stem with a big head welded onto the top of it, and it's very cheap. And if you want to change an Exeter stem, you could just pull it out, leave the cement metal in there, put a little bit more cement in, pop another one. It's very, very easy. So for me, it's a complete no-brainer. You use an Exeter drill stem. Anyone who's a hip surgeon and does trauma in the UK will tell you the same story. Just about everyone in the UK is moving to this stem. It's cheap, it's easy to put in, it's very easy to take out again if it fails, and it's cement. What about unipolar hemiarthroplasty? Oh, sorry, uncemented outgrown dryer. There may be an argument for using them with very, very unfit patients, because putting cement in, some people worry about pressurising cement and getting embolized. There's been some reports, cases about that in the UK. I have a feeling that with very demented patients they may dislocate less, but I've got no evidence for that. Bipolar hemiarthroplasty. Okay, it doesn't work as well as a total hip replacement. That's the first thing. So it's not a substitute for putting a total hip replacement in. There is actually no difference in outcome between a bipolar and a unipolar hemiarthroplasty in terms of function. And there have been, that's one study out there, there are a number of others that have shown that quite clearly. It was introduced because people thought it might erode through the acetabulum less. But that's not true either. It erodes through the acetabulum just the same way as a unipolar hemiarthroplasty does. So there are absolutely no advantages to using a bipolar hemiarthroplasty over a unipolar hemiarthroplasty, and what is more, they're about 4 times more expensive. So my view, and the view of most people now in the UK is, not everybody, because there are still some people who use them, it's a complete waste of time and money. There is no need to use them. Total hip replacement. Now the problem with this is it's a bigger, slower operation, it takes longer. You need a surgeon who knows how to put a total hip replacement in. You cannot leave it to the registrar to do on a Saturday morning or Saturday afternoon while you're playing golf. It has a higher mortality in unfit patients because it's a bigger operation, but the outcomes are much better. And there's a really nice study from Baker in Bristol at the JBJS where they use the same stem, which is the CPT stem, which is actually just like the Exeter stem, and they cemented those in place, and then they either put a big head on it and used it as a hemiarthroplasty, or they put a total hip replacement in. They only did it in fit mobile patients, and they found that without question the hip replacement gave a better result all round. Better scores for Oxford, better walking distance, no difference in complication rate. So for a fit patient, there's no doubt that total hip replacement is the best option. You need to cement it, and you need a good quality stem, and once again, one of these stems are the best because they're the best quality stems around. That's what the evidence shows, and we'll talk about that later. But they're more expensive, or are they? Because some work from the States, and this has just been confirmed recently by a big study done in Scotland, is that if you look at quality adjusted life years and take into account the cost of complications, hip replacement is actually, for the healthcare system, the cheapest option. Because if you fix the fractures, there are so many failures that they end up costing a huge amount, and the patients don't have a very good quality of life. You can use a hemiarthroplasty, but the quality of life of that, although it's a cheaper operation, means that you get less bang for your buck. And the cheapest in terms of quality versus money is a total hip replacement. So, what do I do? If I've got a fit, active patient, and for fit and active, I also substitute in small letters, I'm expecting this patient to live for 5 or 6 years at least, if not longer. I will now give them a total hip replacement. And in where I work, the number of total hip replacements for fracture nexothema was gone from 1 a month. So last week we did 3. So it's ramping up for fracture nexothema. If I've got a patient with limited mobility and limited life expectancy, I give them a cemented hemiarthroplasty, and it needs to be one you can convert to a total hip replacement, and the cheap version of that is the exit trauma stem. If they're immobile and demented, then I would think about fixing them, but in all honesty, I would normally give them a total hemiarthroplasty as well. My practice. Thank you very much. We now have a brief session. This is a very, very common fracture, and we all know how to treat it. But the problem is that because this is so common, it is like dealing with your wife. You go home every day, your wife makes the same food, you don't go and say, hello, how do you do? Nice to see you. You just take it for granted. These fractures are somewhat similar. So let's see what happens and how we're going to manage these. I've got a case up there, and this is an elderly 78-year-old man. Can you all see it? And these are the old days when we had actual films rather than digital pictures. So I'm taking a photograph. Maybe my hand was shaking, or maybe the x-rays were moving. But that's the quality of x-rays we sometimes get in our hospitals. He comes complaining of pain in both his hips. But for the last 2 days, he has not been able to walk because of pain in the right hip, that is, the one on this side. He has come to the accident emergency department. He's had an x-ray. If they've got pain, the A&E department, which has got rules that nobody can stay more than 4 hours, sends them off to the orthopedic ward. So he's now arrived on our ward with those x-rays. He's dehydrated, so he's been hydrated, the usual general medical things are being looked after. What should we do? What is the problem here? I just need volunteers. If there isn't a volunteer, we'll pick somebody in a blue shirt. We'll come to you in a minute. Can you speak up a little? I'm looking deaf.
He says the patient's got avascular process of all in him.
Well, he comes from Sunderland, which is in the northeast, and everybody drinks a lot, including surgeons. So a lot of people have changes which you can put down to maybe avascular necrosis, but more commonly it's going to arthritis. But he's got it in both sides, but he's been living with it for the last 4 years. But 2 days ago, he's not been able to wait there on that side, and that's why he's in. Okay, we've got a fracture neck and femur. Matthew, are you any good at catching this? I just want somebody to show us where the fracture is. William, that's fine. Thank you.
Thanks.
I just want you to show me where you think the fracture is. It's the central button, otherwise the slide will advance, which is not a good idea. Okay, right. Now, what would you do in your institution if you weren't sure whether there was a fracture or there wasn't a fracture? You get a lateral view. Okay. So we got a lateral view, and that was just about as inconclusive. So you think there may be a crack there, but it isn't very clear. What's your next step? MRI. In Sunderland, if I want an MRI of a patient like this who's admitted, it'll probably take me about 48 hours to get.
CT scan.
A CT scan. Yeah. A CT scan will probably take 24 hours. Another X-ray. Okay. Yes. So you recommend on the X-ray path, you need to do a professional standard, and you get that X-ray there. Okay. Right. So there's a truncated fracture. How do we need to manage this? He's now been in hospital for 48 hours, and he says that his pain is a lot better, and he wants to go back home. I think with the health system here, you have two systems where people are privately insured, they privately, and then there's the government hospital. In the United Kingdom, all these people come into a government institution. There is very little private care for profit. So he wants to go home.
We can't send him home like that.
Okay, we can't send him home like that. So what are we going to do with him?
We've got two options. One of them is, both of them are difficult.
We have two options, both of them are difficult.
One thing is to fix that fracture, but it's likely to fail. The fixation is likely to fail.
He says we can fix the fracture, but the fixation is likely to fail.
Because the hip is sick.
Right.
So it's likely that new device will fail. So you're probably going to end up doing a custom-made sort of totally different place.
Okay. So the gentleman tells me that he will do is that what you would do? A custom-made, he would do a custom-made total hip replacement for us. Now, how many people here would agree would do that? I mean, I'm not saying it's wrong. How many people would say this person needs a custom-made hip replacement? A hip replacement. A total hip replacement. So the front row here, who is very senior indeed, say that they would like to do a total hip replacement. What about the yes, the gentleman in the yellow shirt, sir? A total hip replacement again. So though you're much younger than the rest of us, you want to do as well. Any different opinion apart from that? Yes, sir.
I put him in a Thomas and the same here.
You will put him in a Thomas and the same hole. Okay. Okay, you've done that.
Yes.
Sorry, you want to say something, sir? Okay. You want to hold an X-ray. When you do a whole X-ray, you're convinced that it's not a pathological fracture. But that's a good point. Thank you for bringing that up. Okay, let's move on and we'll move on. Okay, so we send him home in a Thomas split, and he comes back 2 days later, and now what the wise gentleman in the audience, which is the vast majority of us here, maybe except for myself, have recognized the fact that he now has a clear-cut fracture. So we now come back to the basic problem. How are we going to deal with this? In a 78-year-old man, 78
78. They're 78 and 2 weeks now. Okay, the gentleman says to me, if the rest of the female is normal, you can do a retrograde nail on the knee. End of it. Okay, okay, because he's 80. Would you think that the implant flexible nail from below would give you enough stability in the gentleman who can't afford it? Sorry?
One day, that for him
Multiple nails. Okay, and you will have to go around to that. To help him on that? You will not go around to immediately. How long would you keep them? What is your post-operative management with multiple flexible nails? Yes. What would you tell him?
The patient is partially mobile.
What do you mean by partially mobile? What would you tell him?
The two hips, which are included to hips.
He's been working with very happy for the last 5 years until he developed this. Okay, and anybody else? Use the
Then these books in the corner nail.
so you want to fix it with the proximal femoral nail. Do you anticipate any problems with putting a proximal femoral nail in this?
This is so.
No. Okay, I think my limited experience with nailing these fractures is even after the decay, this extremely patient to get to their entry point is actually quite difficult. And if I was to I would just hear your opinion. Getting this produced and getting your nail in, adapting the leg, getting the body out of the way is actually quite difficult. And sometimes the only way to have these people is flexion. So you end up flexing it up, and your entry point is from, so you raise the table right up, flex it right up, and you need to nail it from the back. It is a possibility. But whatever implant you use, do you think that the stresses imposed by the limited movement here, or the fixation implant, will cause a problem? Right, one last point, and then we'll move on.
We change this to the pressure total hip
Total hip is the best management. Okay, let's take a home of it now. How many people would agree that you will do a total hip replacement on this channel? How many people disagree that he needs a total hip? Please disagree. It's more fun than you disagree. Let's say the front of you. You have a put on the spot on
I'd ring you.
I would use, it's happy torn, but I think I'd probably perform a total replacement.
Okay, so he's joining the chiropractor. He wants to join the and the last word
There's one point though.
yes, sir.
Can we have it moved?
It's a central one. It's the little ball.
Can you go back just to the past 2 slides? This one looks like there's a lesion there. This looks like it's pathological. Go back to the AP.
Yeah.
Go back to the AP this way.
Yeah.
Okay? Because you've got all this rhythm. That's, I think.
I like you because I might be on this chat. Yes, he's one of our patients. His story about all he isn't quite right because we did recognize him and kill him. But it is often what happens is you get a degree of rotation. And if you have flexion faulty, you get a shoot through you proximally, and you get that appearance. But somebody else will point it out and it's a very valid point. Okay, so we'll move on to what was done, and that's effectively what was done, which is basically a standard order of replacement. It's not a reversion. Okay, did you have time for one more? Okay, this is something that's very straightforward. You see this every day. This lady has cost the National Health Service £100,000 so far in the various factors. And we have usual competence. We have not considered referring her on for bone strengthening and recognition of fragility fractures, because we're very poor at doing it. How are the chances of doing it here? When somebody comes in with a low energy fragility fracture, distal radius, one spine, fracture neck femur, do you refer them on to your physician colleagues for any kind of therapy? You know, well, maybe this is bad, so maybe we'll learn together from this. So this person has come and has got a clear cut injury there. And what we use, we will have to excellent talks and then a brilliant summary of all talks, which is valuable. What should we be doing for this? As an animation, what should I do for it? Sorry? Age. Elderly, say 78, seems a good figure there. Sorry? Yes, that's right, yes. It's a good one, yes, there is. Sorry? Actually, she also, independently relied on her own, she goes about and uses the word around the water. So, without a distance. She lives on her own. Do you want to look at the Anybody? Yes, sir. Gentleman in the black shirt. Okay, we've got everything we know now is an uncemented plastic, because people are sometimes trying to use cement. So is there anybody here who would say we should use an uncemented plastic?
I think also the level of activity. So if he's active, I don't think we will go for cement totally, and if active, go for cement.
She's very limited, she's very limited mobility. We don't have programs into plastic. Similar to plastic. Is there anything there for uncemented plastic?
It can work. It can work. That's a place.
Okay. Well, I'm really surprised because I thought you gentlemen were, very good hosts because you've really given us a wonderful welcome. And I thought I would have somebody here who would agree with what was done. Because that was what we did, and I'm really disappointed that nobody supported us. So that's what we did. But what do you say about that?
It's
an uncemented Thompson's, yes sir.
Actually, I trained here in Egypt.
Yes.
I did all these Thompson's cemented.
Yes.
I was surprised when I worked in the UK.
Yes.
The first case which came like this, the consultant said put in an uncemented Thompson.
Yeah.
I was thought, I'm saying this, man. When after that I discovered that it's a 20-minute job, put the prosthesis in, send the patient back to the nursing home, and forget about him or her, and that's it.
It is a very valuable point, and I think, you reflect on our practice, which causes us some grief and sorrow, because as you've seen from the figures, this is a very, very expensive problem in the United Kingdom, and the problem is dealt with by our most junior trainee. 60% of our travelers, we have all-day travelers start from 9 to 5:30 every day, including Christmas Day. And 60% of the work we do is elderly people with these fractures. And we keep them very happy, because these are the people who are vulnerable, and you get one shot at doing it right, and the other get it wrong. So, how many of you here are now in the court of law? How many of you here are sympathetic to this nice man who has done his best and has done a less invasive operation because he didn't want to put cement into the canal? How many of you think that's all right? It may not be what you would do, but it's okay. I need some support. Please put your hands up if you think that I'm okay and I'm all right with that. No, I think I'm all right. Thank you. Two gentlemen. Can I have some more support? Three, thank you, sir. Can you take this? No. What do you want to do about it? Because read down the line. This is what happens. It is the case of the United States that we have. In the brain of man, and the physical say, why does this matter? What do you do with the brain? What do I do now? I suspect all of you know each other. So if you know somebody and you don't like it, why would you want to them and you ask the question? Yes, sorry.
Have to go and long-stem cemented long-stem possible reconstruction even depending on disability.
Okay, so you want to use a distal fit femoral component, but you want to cement it.
Cemented was
Oh, unscemented. And you want to reconstruct across the femur. Anybody else? Yes, sir. What about you? Seven out of five. Okay. Now the question I have to ask you is, if I'm going to stabilize this with two cerebral wires, I will basically be alleviating that situation. And that was unstable enough. She didn't have a fall. She was just walking and she turned and it broke. So if I put cerebral wires, I will recreate the same situation. And even I am a little, quite adventurous, but I'll be a little careful with that. Yes, sir.
You can use certain levels to reduce the fracture,
Yes?
then put in cemented function.
Okay, so you're basically going to treat it like a perioperative fracture and bypass it with a stent prosthesis. Okay, that's essentially what the gentleman here said. Well, since we've run out of time, the lesson, and the reason I put this up is the lesson that we have not learned, and it was shown is this woman has had a fracture, had that fixed, had a fracture below and had that put in and fixed. And we still did not learn when she came with that fracture that this woman has severe osteopenic problems, and we did not address it, and we treated the most inappropriate implant. And while it's perfectly, easy for somebody who does hip surgery to fix it, it's a very expensive process, which is completely unnecessary and caused by failure of medical management on our part. I think we've run out of time. So sorry,
I have a question that's important to see. You talked about the comparison used by the books from the literature, but you talked about the comparison to the version of one a union to a different patient. Is that still not part of respected by books?
The question was, I talked about the comparison between union and bipolar, but I didn't talk about what happens if you try to convert them from the type of person. One of the arguments that is sometimes put forward for using the bipolar is that you can take the head off and you can then just put it back on. I would argue that doesn't really apply if you're going to use a good quality stem that can be easily removed. And one of the advantages of a polished tempered stem like the Exeter or CPT is that even if you don't want to change it, you can just pull it out. Because it only works by loading in compression. It is not in any way fixed like a shot blasted stem is with a cement membrane. So you can pull that stem out, you can put another one the same size on without a welded head. It's no more difficult than having all your room bridge replacing the back. The other important thing is, and this is why I like using total hip replacement, is there is some evidence that if you put a head in that fails, whether it be unipolar or bipolar, and convert to a total hip replacement, the long-term result is much less slim than if you go straight for the hip replacement. And there's the increased morbidity associated with having second operation.
Does that answer your question, sir?
Yeah. So I can see absolutely no justification for the use of a bipolar because I can't see any advantages. I have also seen several times now where you've got red debris forming between the plastic inner cells of the head and the small head, and you get massive osteolysis. You don't get that with conventional unipolar because there's no plastic.
So you've been running this thing for just what you said. Don't put one head on, but put a unipolar head on the stem. The argument
would be if I need to convert it, I'll take the unipolar head off and convert it to a total hip. But I can tell you, I worked in a hospital where we did that. We used the modular stem for a long time, and we used nearly 2,300 of them to see how many of those modular stems that had a unipolar head on we had converted to total hips. In 2,300, it was 1. So we have wasted an enormous amount of money. They cost about 10 times more than a monoblock. So there is absolutely no reason to spend more money on a modular prosthesis. Something that is a monoblock prosthesis that's all in one will work just as well, but as Matthew says, choose something that you can take out easily, that then you can convert, like the CBT luminous.
In the UK, for what you said, this is nothing but in the UK, the only stem that is monoblock, cheap and polished and tapered is the Exeter drum stem, and therefore just about everyone in the UK now is moving towards it. It's been a huge change in the last 3 years.
Thanks very much, everyone. We'll run the session down, and I think the brief message from all of us, and I'm so encouraged to see that it's coming from the audience as well, is that the most important decision is the first one. Should we fix these fractures? Should we replace them? And if we're going to replace them, we have to make a decision before we go in as to the most appropriate replacement. So it's either a cemented molar in the demented, very low mobility, or it is a total replacement, and there is no third option. Thank you very much.
Thank you very much.